So John, as your role, essentially as a quality officer with a large anesthesia group that is creating standardization of all these protocols, and I think your perspective is interesting because you deal obviously in multiple healthcare systems, not just one single entity. So as you move in your position as the Chief Quality Officer, who are sort of the key players as you go in and try to develop an ERAS program? Who are kind of the key players that you try to bring in to develop this type of or to operationalize something like this?
Right. Well, as you pointed out, it takes everybody that's going to touch the patient, and Declan pointed out that as well. As difficult as it is to come up with standardized protocols and to agree nationally perhaps and even regionally on what best care is going to be, the most difficult thing is the implementation. And that's because of the breadth of folks involved. In academics, it isn't easy. But in private practice, particularly when you're dealing with multiple systems, you can multiply that difficulty by the number of systems you're in, right? So as Zev Kane has said in some of his lectures on the subject, you've seen one, you've seen one. You've implemented a program in one place, you've done it once. The principles apply the next place, but you have to keep doing it each place. And you got to have everybody involved. You got to have C-suite involvement, and you got to have bedside involvement. So I like to think of it as you have to have top-down support, and you also have to have bottom-up support. Just a quick little anecdote, as Declan was referring to, if you don't have everybody on the same page, you will get a nurse who has done the same thing conscientiously for 30 years to take care of their post-op patients, give a patient a large dose of Dilaudid on the floor because they're hurting. And if they don't understand what we're trying to do with multimodal analgesia, the patient says they're in pain. On the VAS score, it's a little higher. As we know, ERAS patients are going to be a little higher on the VAS scores. They give them Dilaudid and you've got an ileus. So that's an example. You've got to have everybody involved, all the stakeholders, a wide discussion, and then the education has to be complete.
So Sanjay, you've gone now from it essentially, so you were exposed to probably some early ERAS protocols as a resident, then you did your fellowship. Now that you're basically an attending at an academic institution, what's been your sort of experience? How has your thinking progressed from the time you were a resident, a fellow, and now sort of implementing this at a system level at a major academic urologic institution?
Sure. When I started, a lot of how we took care of patients post-operatively was certainly dogma. We didn't really have a system in place. And early in my training as a resident, I was fortunate to see the implementation of kind of an early pathway in urology. I think the other specialties were already doing it, colorectal namely, and we decided to kind of implement that. So I kind of saw a lot of the challenges and frustrations as a resident of trying to push out something new that's foreign to everybody. And I think that as time went on through my training and even as a fellow, it continued to evolve in urology. And now as an attending, when I first started working, we didn't really have an ERAS pathway. And so a lot of my work initially when I got there was just trying to get the right people in place and get them all in a room and talk about it and have a discussion about what do we have to do. And even then, we developed a pathway and we implemented it. I think the key thing for us has been just revisiting, auditing it periodically, because what happens is that even though it's on the paper and it says do A through Z, they may not be all getting carried out. And so I think we found out that there's a lot of challenges there, and we try to address those as they came along. But I think for me, just seeing the whole progression from seeing it start out as a resident and then doing my own, I think that we definitely have seen the evolution of it. But I do think a key thing is revisiting it periodically, making sure that it's actually getting carried out how you want it to.
So when you finished your fellowship and matriculated to Oklahoma, I'm assuming sort of Mike kind of put you in charge and say, hey Sanjay, I want you to try to lead this initiative. Was it tough to get buy-in? As Dr. Dalton said, from all these other specialties. You got to have nursing, you got to have nutrition, and more importantly, is what you, as an institution, and I guess we could ask everybody this, is did you bring in surgical oncology, colorectal, gynecologic oncology as all representation of their various disciplines?
Yeah, well, I think when I first started out, we just decided to do it just for cystectomy. And that's kind of just so I could get one thing going, and then we could maybe roll it out to all the different specialties, but just figure out one line. And I think that there really wasn't too much hesitation. I think that certain people who were there a lot longer and had been ingrained in their ways, it was a little harder to move that mountain a little bit, if you will. I think that some of the more younger guys, newer guys, were willing to be on board as well. So I think that certainly was something that we encountered, but the goal was to get one thing working, get it figured out, iron out the kinks, and then once we get a system in place and have some of the nurses familiar with it, the anesthesiology staff, the physical therapist, the nutritionist, all involved, then we could just kind of laterally apply to the various specialties.
This may sound like a ridiculous question, but are there any patients, any surgical patients that are not a candidate for an ERAS protocol?
When we first started, the first month or so, if the patient had end-stage renal disease, or, I would operate on patients that had an LVAD or something like that, we would not put them on. But what we found is that the patients are doing so well, why would we exclude those that have the highest predicted risk and could benefit the most from reduced fluid and reduction in opioids? So in my situation with colorectal, no matter if they're having a small ileostomy closure or a pelvic exoneration, and no matter their comorbidities, they go on the pathway. But we do use our brains and customize the protocol as necessary to accommodate each patient.